Good afternoon, Chair.
Good afternoon.
Hello. Good afternoon, Chair. Yes, I am Fintan Howard. I'm the Chief Executive of the Irish Dental Association, and as you said, I'm joined by Dr. Anne O'Neill, the President of the Association, a Principal Dental Surgeon employed by the HSE, Dr. Caroline Robbins, Chair of our General Practice Committee, a Carlow-based practice owner who holds a medical card contract, and Dr. Clodagh McAllister, our President-elect and a Dublin-based general practice dentist. We're delighted to appear before you today, and we welcome your interest in the concerns we've raised on behalf of dentists and patients over many years. I propose to offer a brief explanation of the original scheme and the medical card scheme today, the difficulties which have prevented resolution of problems with the scheme, possible options we see for reform of the scheme, and the priorities and approach that we believe should be adopted as a matter of urgency. Everybody accepts and I hope understands that oral health is an integral part of good general health. Difficulty in accessing dental care is recognised internationally as contributing to poor oral health for lower income groups due to the high cost of delivery of dental care. Here in Ireland, the medical card scheme was originally designed under the legislation to provide basic dental care to those who met the income threshold provided for within the 1970 Health Act and subsequent legislation. The only other state supports to patients in accessing dental care are within the PRSI dental scheme, which subsidises dental examinations and a scale and polish, and tax rebates under the Med2 scheme, which refunds advanced care for those who can afford to pay for treatment. And in the appendices, we explain the significant differences which exist as regards the operation of the schemes for medical card patients in terms of medical and dental care and the disparity in financial supports provided to doctors and dentists treating the same cohort of patients. I've mentioned also an American study, a very recent study, which shows the impact of the lack of priority afforded to oral health within primary care as regards the growth of inequities within different income groups. And that's very true here in Ireland as well. The PCC study, as it's known, is worthy of closer study. It goes on to say that oral conditions impact the body in myriad ways, and oral disease has been associated with worse outcomes across multiple health conditions and organ systems. The chronic inflammation associated with periodontal disease has been associated with worsening glycemic control amongst people with diabetes, as well as increased risk of preterm birth. Older adults with missing teeth have worse nutrition and are more likely to have nutrient deficiencies. Poor oral health among people admitted to the hospital increases the risk of pneumonia. But more importantly, the impact of poor oral health can't be understood exclusively through potential association with other health conditions. Even without harmfully affecting other health conditions, oral health problems can cause pain, discomfort, and in some cases even death. Poor oral health impacts can also have an effect on employment prospects and an individual's self-confidence, amongst many other economic, mental and social problems. And all of these problems are more tragic because dental disease is almost entirely preventable. Historical differences in how oral health care is delivered and paid for have led to even larger inequities in oral health access and outcomes as compared to the rest of the healthcare system, according to the PCC study. And that's very true here in Ireland and elsewhere. The pre-existing gap in terms of access to dental care based on income disparities has only served to widen in Ireland in the past few years. And the current crisis in the medical card scheme is seeing an acceleration in the health divide between those who can and those who cannot afford to visit the dentist. The current scheme was introduced in 1994, and initially it offered access to basic dental care for all those who had a medical card. It provided access to a dental examination, any fillings required, any extractions required, limited access to root canal treatment for front teeth, and access to basic dentures. In essence, it provided reasonable access at the time to restore and maintain dental health. Private dentists hold individual contracts with the HSE to provide care to eligible patients, and patients are entitled to be cared for and be treated by any dentist holding a DTSS contract. In 2010, 11 years ago, the HSE imposed unilateral cuts to the scheme to reduce expenditure. Those cuts were implemented without consulting with the association, with the dentists or patients, despite the contract having an agreed committee to enable such consultations. And those cuts fundamentally altered the scheme from a demand-led scheme to a budget-led scheme. That was done by removing access for many patients to treatments under the scheme. It restricted access for the majority of patients to one examination annually, a maximum of 2 fillings irrespective of circumstances, and access to as many extractions as are required. It no longer supports the oral health of medical card holders, rather it enables them to lose their teeth and to rely on dentures. Only those who have a significant medical condition from a narrow prescribed range are enabled to access more treatment items on application. The net effect is that any adult over the age of 16 can no longer access the dental care they require to maintain their dental health. In my document, I outline the treatments that were available prior to 2010 and those currently available. So the biannual scale and polish has been suspended. Gum cleaning or periodontal treatment has been suspended. Fillings are now restricted to 2 per annum. Root canal treatment, dentures, denture repairs are all only available in emergency circumstances. There's an unlimited number of extractions still allowed. So for the patient, it means a lifetime of embarrassment, decreased nutrition and loss of well-being. The association, as a party to the regional agreement, has advocated both on behalf of our members and the patients who attend them for many years. It's our view and the express view of our members, the dentists operating the scheme on a daily basis, that the state scheme for approximately 1.5 million eligible medical card patients is in crisis and on the brink of collapse. The last year has seen an unprecedented number of dentists withdraw from the medical card scheme, with serious repercussions for patients across the country. Total spending on the scheme fell from over 63 million in 2017 to barely 40 million last year. The implication of this is that large numbers of patients are no longer accessing treatment, as the scheme is a fee per item structure. A detailed breakdown on the impact of the cuts in spending on patient attendances by HSE CHO region, and also an illustration of the reduced number of DTSS contracts held by dentists by CHO region has also been supplied to you. The current sets of fees paid to dentists are in place since 2010, when fees were reduced under the FEMPI legislation. Any changes to fees require decision by the Department of Health. There's been no review in the intervening period, no reversal of the cuts imposed. None of the items currently provided are economically viable in terms of the costs incurred by dentists caring for patients. And many of those treatments are no longer in line with modern best practice dental care, and my colleagues would be happy to expand on that. Last week you heard from the HSE, and they said that in a typical year, just over 30% of the eligible population received treatment through the scheme. Last year it fell to barely 22%. The HSE said mainly due to the COVID-19 pandemic. The number of claims has fallen dramatically in the last number of years, and in 2019 there was over 1 million. In 2020 there were less than 800,000. The number of contracts held by dentists nationwide has fallen by over 30% between 2015 and 2020, from a figure of 1,847 to below 1,200 at present, and we believe that the current figures are significantly overstated due to many inactive contracts. The fundamental changes in the structure of the scheme and the reduced number of participating dentists has had very significant impacts for patients. Patients are experiencing delays seeking treatment due to the reduced number of dentists participating. Patients are experiencing delays in accessing treatment while administrative decisions on whether to fund additional care are made. Patients are looking at increased travel time seeking treatment, and in some cases they're relying on the already underfunded public dental service to provide care in areas where DTS contracts are particularly scarce. So what we are seeing is an unprecedented crisis in dentistry and access to dental care for the most vulnerable of patients. In 2020, almost a quarter of participating dentists nationwide left the scheme, and we see this scheme is no longer viable, and that's the decision that those dentists have also arrived at. They simply can't afford to continue to participate, and this is leading to complete chaos. And in the footnote, I make mention of the fact that the last straw many dentists said for me was, when they were promised PPE within 7 days last June by the then Minister for Health, and it still hasn't materialised. And for many dentists, they said that was the last straw and led them to resign. The withdrawal of dentists is also affecting services provided by the HSE's own dental services, which are now faced with adult patients presenting when those same public services have seen a 24% reduction in staff at a time when there's been a 20% increase in the number of eligible children seeking care from the HSE service. And all of these impacts are without considering the substantial impact of COVID-19 on providing dental care. Not surprisingly, our members continue to voice their anger and disillusionment with the government's lack of action on the matter. We've sought to engage with the Department of Health to redevelop the scheme over many years to no avail. And many of our members believe now that the refusal to acknowledge the reality of the crisis within the scheme and the general of the approach of the Department of Health suggests a level of disrespect, if not contempt, for the profession, the importance of dental and oral health and the patients who rely on this scheme. It also shows scant regard or understanding of the impact of this crisis on vulnerable patients who are unable to afford access to a service, which was defined as essential by the government during the COVID crisis. Significant extra costs incurred by general dental practice during the pandemic have raised the cost of providing care to patients and have made the existing DTSS contracts completely unviable. Dentists do want to be able to provide care for all patients, but the government is leaving them with little choice but to minimise their involvement or to withdraw from this scheme. The association is the representative body for all dentists and was party to the negotiations which culminated in the introduction of the scheme in 1994. And the need for the redevelopment of that scheme has long been recognised. Negotiations on a revised scheme were abandoned in 2007, that's 14 years ago, when the Department of Health withdrew from negotiations, citing concerns about the role of the association having regard to competition law. We don't accept that there's any impediment to our participating in collective bargaining with the Department of Health, and we have corresponded and discussed this with the Department over a long period. To overcome any concerns on this issue, as recently as last November, we presented a modified version of the so-called Framework Agreement, which was concluded in 2014 by the Department of Health and the Irish Medical Organisation, which represents doctors in general practice treating the same cohort of patients, to reflect the specific role of the Irish Dental Association in representing general dental practitioners. We've not received a response to those proposals to date. We stand ready to negotiate with the Department of Health. We have successfully negotiated with the Department of Social Protection in recent years on the extension of the PRSI dental scheme to eligible self-employed persons and the restoration of the scale and polish in 2017. And we are perfectly confident that we can engage constructively with the Department of Health if the threat of criminal sanction is removed from the association. The association is also committed to promoting independent practice, and we have provided you with a copy of our independent practice policy paper published as late as 2019. We recognise the need for support from the state in allowing low-income and marginalised groups access to dental care within the context of promoting independent dental practice. However, the legitimacy and role of the association as the sole representative body for the dental profession must be recognised and secured within an appropriate framework agreement. As the representative body, our association representatives believe that the priority in addressing the current crisis should be on ensuring proper access to dental care for those who face the greatest difficulty in meeting the costs of treatment. Any arrangement has to be economically viable for dentists and can't have an administrative burden which delays patient care. And there also must be clarity as regards care pathways for eligible patients. Patients or dentists shouldn't be put in a position where they have to barter about the care to be provided. We believe that a fundamentally new approach is required to address the need to restore access to dental care for lower income groups rather than more of the same with a failed model as exemplified by the current system. We believe new models of access need to be examined, including a combination of some or all of the following approaches. Application of a co-payment system similar to that used with the PRSI dental scheme. the use of use it or lose it vouchers funded by the state to encourage greater attendance of patients for dental examinations and possibly other preventative treatments. And there are examples of that in many countries. Expansion of the Med2 tax relief scheme. It was indicated by Department of Health representatives appearing before you last week that they favoured an interim solution prior to beginning a root and branch review of the DTSS. Our members have been very clear in voicing their opinion that applying a shot of adrenaline to the current scheme is not an acceptable solution. It's long been accepted that a new dental scheme is required, and it can't wait for the pandemic to be over before comprehensive discussions begin. We're available to engage in discussions which will, within an agreed timescale, produce an agreed long-term solution to the current crisis, but equally on the basis that any short-term interim solutions are credible and are consistent with the principles we outline within this document and have a finite lifespan. The legitimacy and role of the association must be recognised and secured. Ultimately, we believe that the following principles must apply to any scheme or approach developed by the state. There must be a time-limited review of any new arrangements. There must be a complementary role. The complementary role of the public dental service must be recognised. There must be clear referral pathways agreed and adequately resourced within the public dental service. There needs to be clarity around the scope of treatment coverage for patients and dentists. Any changes in the scopes of treatment must be reviewed regularly. It's vital that there's clarity as regards the state's responsibility to provide care to eligible patients where elements of a treatment plan are not covered. Any obligation resting on general dental practitioners and funded by the state have to be clearly enunciated. A demand-led approach cannot operate in tandem with caps on funding. Agreement has to be reached on the maximum number of eligible patients any dentist can be required to care for and treat in any scheme. Bureaucratic overload has to be avoided. The autonomy of dentists and dental practices must be recognised by the state, along with the imperative of dental practice to secure the viability of their business. Professional fees have to be structured in an economically viable manner, having regard to the operating costs incurred by dentists, and with provision for regular review on an agreed basis. Unilateralism on the part of the state is not compatible with a collaborative approach to working with the profession. And finally, structured dialogue in any forums attended by state agencies and the IDA must be enabled, along with agreed dispute resolution, grievance and disciplinary provisions. Thank you very much for your interest. We'd be pleased to address your comments and queries.
Okay, thanks very much. That was a long opening statement, but appreciate it, and there's a lot of detail there. So our members will now ask you questions. The first member to come in is Bernard Durkin. Who's on mute, and it's the quality of your phone is not great, Bernard, either.
There now. Is that better now?
Yeah, we can hear you. Anyway, go ahead.
That's all right. Okay. In any event, welcome to our guest speakers and thank them for their presentation. And to go back to the very start, a question is, when did you last consult with the Department of Health in relation to the issue that you've just raised with us now?
We last met with the Minister and his officials in a meeting which took place virtually last November.
Mm. And was the meeting successful, satisfactory, or unsatisfactory and unsuccessful?
Well, it's always good to chat. There was supposed to be a follow-up meeting. It has yet to take place. It was an opportunity for us to spell out, as we have done, or as I have done here already, the concerns we have, but there was no follow-through, and that's a matter of some concern.
You have done very well in setting out the various aspects of the service and the needs of the service. I should mention, I suppose, that I have had numerous visits to your colleagues over the last number of years, and I've had lots of grounds for satisfaction. So I wouldn't be a critic of the service at all. I'd be a strong supporter of the service. But anyway, the next part is this thing about the restricted extent to which examinations and treatment can take place in any given year. Is it in a calendar year, or could it take place instead of 2 examinations? Could you have 2 in November and 2 again in February or January? And can they be into one?
No, the schedule applies on a calendar year basis, so you're entitled to one examination in a 12-month period from January to December.
Okay, that answers that question. In relation to medical card in general and the number of patients on the card, the number of patients has increased, and there are. Can you remind us again the extent to which the number of patients has increased? The demand has increased, in other words.
Well, the number of eligible patients is currently at 1.5 million. It has increased from 1.4 million, probably, I'd have to check the figures, probably maybe in the last 5 years. But of course, it's also important to remember that the participation, so usually about 1 in 3 eligible patients would visit their dentist for at least an examination. But as was confirmed, it's now down to barely 20%, 1 in 5 in the past year, for understandable enough reasons in lots of ways. But even in normal times, barely 1 in 3 eligible patients were availing of the scheme, which is a pretty damning indictment of the scheme in ordinary circumstances.
How well have you exchanged views with the department and the HSE in relation to maintaining good oral hygiene and early detection and so on?
Well, I suppose many patients and many members of the association would probably say we haven't been very effective if it's persisted and declined as much as it has in the last while. But I can assure you, and I've appeared before yourself and many of your colleagues before on other occasions. We believe we have been very consistent and vocal and clear in presenting our concerns, but really there's a lack of urgency within successive administrations. We had the same problem with previous governments and previous administrations, which we find very difficult to comprehend.
And have you tried the avenue of strongly illustrating the importance of the service and the importance insofar as the patient's health is concerned, their general health is concerned, and how well have you emphasised that when dealing with the powers that be?
Well, I think we have. We have never encountered a situation where people have said to us that there isn't an acceptance that dentistry is important. Dentistry was regarded as an essential service at the start of pandemic. Dental practices have remained open. The state has recognised that it's important that patients are able to continue to attend with all suitable precautions being put in place. So on the one hand, there's no doubt but that the state and the authorities recognise that dentistry is important. They don't follow through, in my opinion, with adequately funding the service, particularly for those who have the most difficulty.
Okay, I'm going to move on to David Cullinan.
Okay.
Thank you. Can you hear me, Harlock?
Yes.
Thank you. Okay. Welcome to Fintan and others from the Irish Dental Association as well. Fintan, I want to start with a quote that we had from the HSE last week when they were before the committee. And in their opening statement, they referenced the DTSS scheme. And it was simply one paragraph, and this is what it said. HSE is aware that some medical card holders have experienced difficulties in assessing treatment. Where this is made known to the HSE, each inquiry and representation is followed up by local community services who seek to assist medical card holders. In your view, is that a gross underestimation of how serious the crisis is?
Absolutely. I mean, I think that the facts speak for themselves. There's been a huge decline in the number of dentists participating in the scheme, and related to that, there's been a huge decline in the number of patients availing of benefit under the scheme. Where a dentist leaves the scheme and a patient presents, the scheme is very clear that the responsibility rests on the HSE to find another dentist. And I know from speaking to HSE officials that in many parts of the country they find it next to impossible to find another dentist because there's been large numbers of dentists have left the scheme. So the consequence of that is either that a patient travels a great distance for treatment, they postpone treatment, they receive no treatment, or in a small number of cases they have to borrow or find money to pay to be treated privately. So there's no doubt when you see that in a normal year that 1 in 3 patients get some benefit from the scheme, and last year 1 in 5 patients were going to visit the dentist, there has been
can I ask from your perspective, because obviously you've been involved with the association for some time. In your view, is this an unprecedented crisis? So, like, are we talking about a full-blown resourcing crisis here?
The situation has never been as bleak as it is currently. We know from the phone calls we get from members of the public to our office. We know from the dentists participating. We know from calls we've had from politicians, from local radio stations. There has never been a problem of this magnitude or scale in the history of the scheme, and never has there been so quick a decline in the operation of the scheme as there has been.
Just in terms of that decline, then, if I can just hone in on some questions. So we know that there has been a 31% decline in funding from 2015 to 2020. But there was also a substantial decline in dentists that were contracted from 1,847 to 1,279. I think that's the number. So in your view, over the last 7 or 8 years, or whenever we started to see a decline, how many less dentists are there signed up to the contract now are there than we had, say, a number of years ago when we first started to see the decline? So, like, how stark is that number?
Well, I think, you know, what was remarkable is that in the difficult years after 2009, the number stayed pretty consistent. Number of dentists participating in the scheme stayed. But in the last 5 years in particular, in the last 3 years, there has been a sharp decline. The rate of decrease in the number of dentists has never been greater. Last week you were told that they have done a further audit of the contracts. Our belief is that in fact the figures are actually worse than the official statistics indicate.
Is it possible, Fintan, that there are some what you could describe as inactive contracts? Is that maybe where some of the confusion is?
We know for a fact, I'll give you an example. I was talking to one dentist and he said that in his practice there was, until fairly recently, 5 dentists holding contracts with the medical card scheme. It's now down to 1. But when he went to check the database, which is published on the HSE website, he saw that all 5 were still listed as being active. So we well believe that the system, the official statistics are grossly overstated. In fact, my best guess is that there are actually less than 1,000 dentists currently participating in the scheme.
Well, I think, Cahill, what we need to get to is that exact figure, because we were quoted a much smaller figure from the department and the HSE when they were before us last week. So I do think we need an accurate figure from the department and the HSE in relation to how many dentists are currently signed up to the contract, and then how many are active or inactive. I think that would be important information to have. But just to move on to the treatment side of it, because we have a shortfall in funding, we have dentists who are leaving in unprecedented numbers, we have medical card holders who, because of that, maybe are not getting access to the service that they need, and there isn't a pathway to more serious treatment, as we know as well. So looking at what treatment is available from 2010 onwards to what was available prior to that, it strikes me, and I just want to get your opinion on this, that we've almost abandoned prevention. And we're saying that when it comes to scale and polish, when it comes to extended gum cleaning, it's all suspended. When it comes to root canal treatment or dentures or denture repairs, it's all in emergency circumstances only. And unlimited numbers of extractions, which to me doesn't make any sense. So what we're saying to medical card holders is we're not going to put the preventative resources in place and give you an opportunity to go to a dentist to prevent it getting to a point where you need an extraction. But if you get to that point, we'll happily remove the tooth, which is hardly good oral health. So from your perspective, am I right in saying that? And is that something that you have highlighted yourselves with the department?
I'll ask Dr. Anne O'Neill to comment on it, but it has certainly been a comment that we have heard from dentists over the years, is that the changes made in 2009 and 2010 sat very uncomfortably with many dentists for the very reason that you have outlined there. People are now going to be put off going to the dentist if they feel that there's no limit on the amount of extractions, but there are limits on the number of fillings, to use that basic example. So I might, Anne...
just before you bring your colleague in, I just want to reinforce some of what I've said with with data that I got back from parliamentary questions in relation to orthodontic and dental waiting times in the public system, because that's also a very big issue. So children with special needs, for example, there was 104 children with special needs waiting for more than a year. In terms of children waiting for dental extractions under general anaesthetic, which I'm assuming is an emergency, there's 1,500 on the waiting list, and hundreds of those are waiting longer than a year. In some cases, 2 years. And then when you move to the orthodontist wait times, which is really staggering, 15,313 people on orthodontist wait times. 2,439 are waiting more than 4 years. And if you look at some of the regional disparities, the southeast, it would seem, is the hardest hit area. So again, while your colleague is coming in as well, is that adding to the problem? Where not only now do we have a problem with a drop in funding, dentists that are not are dropping off the contract, not providing the service anyway that should be provided in terms of prevention, waiting until it gets very serious, and then if somebody needs orthodontic treatment, well then you're on a long waiting list, anywhere from 1 to 4 years or longer. So I just add those statistics in terms of the information I've got from PQs. Does that tally with your own analysis of how difficult it is to have that pathway to more urgent treatment, I suppose?
It does, and what we are seeing is that there are now new waiting lists. So it's well recognised that there have been orthodontic waiting lists of unacceptable levels for many years. But what we're now seeing is that there are waiting lists emerging for care for children, children who require treatment under general anaesthetic. The school screening programme is effectively suspended or abandoned in many parts of the country. And that's because the public dental service is now, it has been historically understaffed. Public dental surgeons, and Dr. Anne O'Neill is one of them. Many of them were redeployed over the past 12 months to work with testing and tracing. So what you're going to see is, in fact, these new waiting lists grow exceptionally and exponentially longer because the public dental surgeons aren't available to see both children and special care patients.
Well, Fintan, I've only, sorry, apologies, there's a very short time left, and I just want to make one last comment before your colleague comes in. There's also going to be, in the health services generally, a need for a lot of catch-up care, as we know, because a lot of non-essential care was paused. And obviously, in dental and orthodontic services in the public system, there was a pause for a significant number of months. So the figures from March to the end of May for 2019 was 45,924 appointments. For the same figures in 2020, same date in 2020, was down to 3,161. That's huge. And again, I would imagine that's carried over as well into 2021, into this year. So while my time is short, and I know one of your colleagues came in, I wouldn't mind if you were able to, if it's not yourself, your colleague, address that point as well. So with all the other problems that we've just identified, we now have all of this catch-up care that will now need to be done as well.
Does someone want to briefly reply to those questions?
I'll take up the questions that Deputy Cullinan has raised. The easiest way to actually look at these is actually to looking at mapping the patient journey. And while I can appreciate that the numbers of practitioners within the DTS is one of the trends to look at, the second trend to look at is actually the number of active and the amount of resources that are available in all of the geographical areas. Because while somebody may have a contract, we have got staff who have not yet been able to resume services because of COVID, because there are additional difficulties now with pregnant women past certain ages actually participating in care. And we have got people who are more mindful of their own general health because of the impact of COVID. But the problems with the DTS are not COVID. They're not of COVID's origin, but I think COVID could be really called the nail in the coffin. If you look at the journey that a patient now takes, if you talk about the child patient, because you've actually referenced the need for general anaesthetic care, unfortunately, general anaesthetic care requires hospital facilities. So you're automatically in competition for access to the same resources that provide treatment to scoliosis patients or cardiac care. Those patients are coming from the underfunded child service, and they hit the DTS service at the age of 16. they're not able to access the number of fillings that will allow them to reach what a dentist would consider to be a state of health. So while the preference, of course, would be not having a need for fillings, if they can't actually access the number of fillings required to bring them to a stable oral health status, then they will end up losing those teeth earlier than would be desirable. One of the differences between our current policy and the previous policy, which was the Dental Health Action Plan, was it set targets for health for people, whereas the new policy talks about access to care, which of course is an issue. But without having both in the same concept, then you're going to find that it's going to be very difficult to ensure that there's resourcing there for patients to be able to get the level of care they need. With regards to the numbers, the appointment numbers that you're talking about in COVID, yes, they would all fit into the general understanding we have of the resource difficulties that the entire system is in at the moment. There's no doubt about it, orthodontic waiting lists historically have always been long. Because the treatment plans are long, they tend to take batches of patients from the waiting list from time to time, and it's a 2-year treatment plan. But I think you'll find that more patients are interested in having orthodontic treatment than ever before, so that they are more interested in being put on the waiting list. They will wait for their treatment time because it is an expensive treatment. And it's not, the orthodontic waiting list is not limited to those with or without resources. It is children of clinical need, so that it covers all of our child population. The difficulty that COVID has put on us is actually on top of an already under-resourced system. So we're at crisis point with all of the entire range, but in particular our issue with the DTS is that the activity required to start mediating the problems that exist rests with the department.
Thank you. Our next contributor is John Larhart.
Thanks, Chair. How much time have I?
You have 10 minutes.
Okay, I've started my stopwatch. All that talk of root canal has brought me out in a goosebumps and a rash. I say kind of humorously and half, very definitely not humorously. Just in relation to a number of questions that my colleague David Cullinan asked, because they were ones that I wanted to ask. If I was to ask just a summary question, that the focus of the DTSS tends to be reactive as opposed to proactive. Would that be a good summary? Okay.
Yeah. They can't simply, and I have done all the work for them, and I've adapted the 2014 framework agreement, presented it to them, and still I'm waiting for an answer. So I don't think there is an alternative, and I don't think any scheme would succeed without the implicit and indeed explicit support of the Irish Dental Association. So yes, that does need to be addressed as a priority. As regards the scheme being out of date in terms of best practice for patients, I'd invite Caroline to explain.
Thanks, Fintan. Look, I'll keep it very simple. I'll put it like this. The contract was formulated in 1994. I graduated in 1995. The dentistry that I do today is vastly different to what I did back in 1995, and rightly so, it should be. And I don't think any patient sitting in my chair wants to be looked after by a dentist who has not kept up with the science and the evolution of materials that we have today. Just an example, just to keep it simple for you, is back in 2018, we passed the Minamata legislation in the reduction of amalgam waste in the environment. So now that makes me, I'm not legally allowed to place an amalgam filling in a pregnant patient that presents to me, yet my contract only allows me to place amalgam fillings in back teeth. So I also, the budgetary, the things that were removed back in 2010, one of them was the A6 dressing or a temporary filling. I can't even place a temporary filling. So then I'm stuck with the position of all I can offer this patient is an extraction, which again goes back to the very point that we're making. That is just solving a problem, taking a tooth out, there's a problem gone. There's no more money needing to be spent on it. So it's, the science has moved on, dentistry has moved on, yet I sit my patient, and my contract would tell me that I am to treat my medical card patients as I would treat my private patients. And that goes without saying. Yet when I sit them in the chair, I am not allowed, I am then suddenly faced with very limited to what I can offer them. There's no autonomy for me to our teeth, for example, and choices of what I can do for them. So the science has moved on, dentistry has moved on, but the scheme has not.
If there's a comprehensive list or examples, perhaps you could provide the committee with that as well. But those ones are very interesting as well. Can I just touch on the resourcing of the school screening service from the HSE is presumably having a knock-on effect in terms of people then who are presenting with issues that should have been picked up in school setting that haven't been. And I've come across cases where people that weren't picked up in terms of having an underbite or an overbite, and the cost there that puts then on parents to try and sort out when a child has just gone 16 and has missed the window, if you like. Perhaps just finally, Deputy Larhart touched on vitamin D, and we launched the report yesterday. Is there anecdotal evidence of dietary issues impacting on oral health at the moment? And I know there's fortified foods, but let's say the reduction in the use of dairy, perhaps in some young people, perhaps, is that presenting in terms of problems in terms of oral health?
If I might, there's an awful lot of feedback. If I might come in on that, because it falls into kind of the dental public health sphere, we have issues arising with the frequency of sugar. Tends to be the hard tissue basis for increasing rates of dental disease. So things like a widespread consumption of sugary drinks is a big issue. There is some concern about the reduction in calcium sources for girls of certain ages, which then have implications for osteoporosis in later years, because depending on what the commonplace trends tend to be, taking dairy out or taking wheat out and things like that, alter the food basis. With regard to reductions that positively impact on dental health, then you're looking at the model of 3 meals and 2 snacks as being positive, whereas the grazing model and ready access to foods and secondary school kids having money to be able to buy snacks on the way home, all of those impact negatively on oral health. You talked about the under-resourcing of the school screening system. The difficulty that imposes is that you have 16-year-olds arriving into the adult medical card scheme who haven't been able to access a comprehensive treatment plan. So they're coming in, they may have 2 or 3 cavities that need to be managed, but they'll only be funded for 2, so that they're automatically starting at a downward point. The trends, we would have looked at trends in the HSE, we would have funded and participated in epidemiological studies, and nearly all of them showed that the teenagers, the 12 to 15-year-olds who get that extra independence, they get a little bit more freedom in what they're able to purchase at their own behalf, that they tend to have that higher level of decay starting to arrive because they're no longer under the same level of parental control. But I think the ready access to sugary-based foods and sugary drinks is still contributing significantly to decay rates. So, there's a lot of work that can be done in influencing positive habits during the school ranges, but it needs that timed intervention over longer periods so that children are supported in learning the good habits.
Okay, thank you very much. Have I time for a final question?
Yeah, have Sean, yeah. Go ahead.
Yeah, just you talked about the administrative burden. The last check I got for a checkup I got, and they didn't just go into the screen and inputs your PPS number, which of course we cannot claim anything back because of the Class K stamp. But anyway, that's another debate. But what level of burden really is there?
I think it's the burden. It's the burden that the dentists face. So it'll be pretty straightforward for the patient, but for the dentists, they face a number of obstacles. I suppose, as was explained, there will be some presentations where the dentist will say, you need a certain treatment, or I'd recommend this certain treatment, but we need to get what's known as prior approval or permission from the HSE dental team, and they'll have to supply a lot of documentation to support it. Now, that's not something that applies ordinarily. The other administrative difficulties tend to be around form filling, claims that are submitted for payment and rejected and then appealed. It's just there's a strong sense of unnecessary bureaucratic overload with the scheme, and that's one of the reasons why we think an entirely new approach is required. But just to clarify, we're saying that the administrative overload is from the perspective of the dentist rather than from the patient.
Oh yeah, well, I assume that, but I was just wondering from the dentist point of view.
Could I add something to that, if you just would like to get an example? So, for example, if you came in as a private patient, if you sat in my chair and you had a problem, we can talk about what needs to be done, and we can get on with it straight away. If a patient sits in my chair who has a medical card and talks about a problem, the first thing that I need to do is go to my computer and go to the relevant payout on that health checker to see if I can actually do that filling on the patient. Because if that patient has had that filling done here or elsewhere within the last 5 years, I'm not entitled to do that filling on them. They won't pay for it. So then I'm faced with either telling the patient, I'm very sorry, they're not going to pay for it. So I now have to send for approval. So that's a bit of a wasted appointment for you. I'm very sorry that you're in pain and it's uncomfortable, but my hands are tied because I'm not actually allowed to do the filling for you until that approval comes back. So that's just an example. If I'm filling in forms at the end and I go to claim a tooth has been extracted and I get told on the form that tooth has previously been extracted, and that can happen, that's just charting mismatch. I then have to write to the chief dental officer with all the x-rays in the patient's file, ask them to alter their file in the central hub, and then wait for that to get recognised at the PRCS, and then try and claim again. So it's very clunky, and it takes a lot of time. That's just to give you a basic idea.
Okay. All right. Thank you, Chair. Thank you.
Do you want to sum up, in relation to some of the points that you might have felt that you didn't have time to address? So we're coming to an end of the meeting today. I listened to what you're saying, that you last met with the Minister back in November, and I will certainly follow that up from today's meeting. The PPE, none arrived. Again, it's outside the remit of today's meeting, but again, we'll write to the Minister and try and pursue that. The 6 front teeth treatment only that you talked about, the quirks in the system, we'd be really interested if you could follow up from today with those restrictions that are clearly there that were so eloquently outlined in your contribution, particularly the fact that someone is coming in a lot of pain and yet you can't follow through on that particular treatment. We're particularly interested in the amount of dentists that have actually left the scheme. I think the last report that we got from the HSE they were talking about 199, but I know that in the media there's figures quoted as high as 240. You talked in terms of you could look at a map and you talk in terms of the black spots that are there, the gaps in services, and you have a number of charts that if we had the time I'd probably like to go through, but if you look at the decrease in spendings, I think the CHO6 area is the highest with 41% decrease in spending. You look at the Clares, the Kerrys, the Mayos, the Dublin Wests, right? That right across the coastline. And again, I suppose that was one of the questions that we were asking the HSE. Was it a rural, was it an urban thing? But clearly from your charts here today, it's right across the state in relation to the gaps that are there. And I suppose it's people who are on medical cards, I suppose, are the ones that are suffering the most. So is there anything else that you'd like to add to us today? But we really appreciate if you could add to anything you contributed here today as part of a report, and I think it was really helpful, your contributions here today. Apologies if I cut some of you off. Unfortunately, that's the nature of this. We have to be out of the room within 2 hours, so there's a bit of pressure on. So that's why the idea of 5-minute introduction, 10 minutes then for the larger parties, and 7 for the smaller ones. So if you just want to maybe sum up, or if there's something else you'd like to contribute in the couple of minutes that we have left.
Well, maybe if I could just very quickly say for completeness that the Minister for Health has said that he will address our AGM, which takes place on the 8th of May. So we certainly hope that he will get a report from today's meeting. He's well aware of the issues and that he'll have something positive to say. I think just very quickly, just to reiterate, dentists do want to provide care for all sections of the community. The medical card scheme, its original intention and purpose was well-meaning, but it's long past its sell-by date. We believe that a new approach is required. We believe that the representation issue needs to be resolved as an easily sorted impediment, but one which hasn't been resolved before now. We believe we have plenty of good constructive ideas. We believe we have a track record of success with negotiating innovation, and that our members do want to see new arrangements in place which work for patients and work for dentists. So I see at least a couple of my colleagues have their virtual hands up, so I leave it at that. And finally, to thank all of the deputies and senators for their time. We always know it's an uphill struggle to interest people in dentistry, and the point was made, we're not succeeding in explaining the critical importance of oral health within general health. So we very much welcome today's opportunity. Thank you.
And do you want to come in next?
Thank you for that. And thank you for the interest that you've shown this afternoon. It is reassuring that for all of you that were actually at the meeting, that you understand the connections between health and dental health. The comment that I would have is that while many within the system actually understand and would agree on the difficult areas within the system, what is actually needed is activity and engagement. And with the difficulty that dentistry often has is that it must beat everybody else to the post in order to gain the high level of priority needed for the available funding. That will be enabled to some extent if there are people who are championing the issue of oral health and oral health for children and oral health for vulnerable adults. I think we need activity on the implementation of the oral health policy to get that engagement, because we are quite aware that that is the tool that's going to be used. But we can't wait for pandemic to end. We need activity now, because the problems have been building for so long that I'm seriously concerned that by the time pandemic ends, we won't actually have a dental health system to save. And that would be very regretful, because the DTSS was innovative for its time. It needs a successor. And thank you.
Thank you. Who else? Anyone else?
Yeah, it's Clodagh.
Clodagh, yeah, please.
Yeah, I just wanted to say that it's the most vulnerable in society that aren't being looked after, and we have a duty of care to look after them as citizens and as professionals. More importantly, the government have a duty to look after them. So what they're doing is wholly unequal. It means that one section of society can access care and another section can't.
Thank you. And finally?
Well, I just to concur really what Clodagh has just said, you know, from the human point of view, from my side, I feel like I have three personalities. The human side is that I really have looked after these patients, some of these patients for 20 years, and I have a deep care for them, and the scheme as a whole is a good idea. And I come from a country that at this very moment is looking to try and implement an adult scheme like this. So they're watching us with avid interest. From a clinician's point of view, I just find myself exasperated that I just cannot offer my patients basic care. It's fundamentally, at times, inhumane, and I feel very bad about that. And then from the horrible part, as a business owner, it is incredibly hard for me to persist with this scheme as it stands. And I don't like to say that. It's like the elephant in the room, but that is their sad reality. But we owe these people a lot, and I think that, you know, I would be hoping, and thank you for having us today, because it's been really nice to be able to air how we find it and how we feel, and maybe give you a better insight to what our day-to-day is like. So thank you very much.
Thank you, and I you know, again, concur that you know, there's nothing worse than people feel being ignored or left behind, and I can understand people being upset, particularly around the PPE. So just on that note, you know, want to wish you and your members every success in the future, but also that you know, wish you every safety in these difficult times. So you're at the coalface and dealing with people, and long may you continue. So thanks very much. So I'd like to, that concludes our meeting for business today. So the meeting now stands adjourned until next Tuesday, the 13th of April, when we get a briefing from the National Public Health Emergency Team, NEFIT, on the response to the COVID-19 pandemic. Thanks very much.
Thank you.
Thank you all.